Okay, guys, so let's start our today's session. So thank you so much for joining our second session for first aid AMC clinical. We are doing the pediatrics vomiting cluster tonight, which is very important for your exam. Now, as you know that we have been doing our classes based on the clusters. So you have finished with us the cardiology. So in the cardiology, we covered your palpitation clusters, we covered the syncope clusters, and also we did the chest pain cluster. So tonight we are going to do the pediatrics vomiting cluster. Okay. So let's see if there are other people has been joined or not. And we will do the cardiology role play session somewhere in our 11th November. That means in your next session, we will try to do the pediatrics role play and also the cardiology role play. So in that class, we will cover most of the role play based on the cardiology and pediatrics. We may not be able to finish both cardio and pediatrics role play in one class. So we'll take some other session on that. Okay. Let's start then. So, vomiting cluster. Before anything, we usually, when we start a cluster, we has to know the differential diagnosis of that particular cluster. As you guys already should know that normally we will start with a cluster and then that differential diagnosis we will cover, and then we will make a format for asking the history, and there will be another format for physical examination from examiner, and then we just need to finish the cages. In that way it becomes really concise and you will understand what question to ask, even though if you may not be able to memorize everything. So if you follow a format, eventually you will be able to cover all the important things that you need to ask in the history, that you need to ask it from the examiner. Okay. So for vomiting in children, what are the differential diagnoses we have got? We have got GIT causes, we have got non-GIT causes. What are the GIT causes of vomiting? So GIT causes, you have gastroesophageal reflux, you have pyloric stenosis, duodenal atracia, incarcerated hernia, intussusception, volvulus intestinal obstruction, Hirschsprung disease, and acute gastroenteritis. These are the main causes of vomiting in children, which is related to gastrointestinal. So for your exam, the important cases are pyloric stenosis, duodenal atracia, reflux also not very common, but yes, it's important to know. Then incarcerated hernia important. Gastroenteritis usually comes with diarrhea rather than vomiting. Then these are not very important. Intussusception comes, but it usually comes with abdominal pain rather than vomiting. So you see that all these cases are little bit of like one or another way. These are very important for your exam. And also any child having vomiting, you should always try to rule out the infectious causes of vomiting, which are the non-GI causes. So UTI, then otitis media, pneumonia, septicemia, or meningitis. So mainly urinary tract infection, ear infection, meningeal infection or inflammation, so meningitis or septicemia, chest infection or pneumonia, and sometimes torsion of the testes can cause vomiting in children. So these are the main differential diagnoses. So you have got GIT causes, non-GIT causes. Now the history is a little different from the adult medicine cases that we have done in the cardiology classes. Pediatrics, the good thing is that we have a format, and if you know the one format, you can use the same format in every pediatric cases. So that's huge, and that's really easier for you to ask questions in regards to pediatrics. any cases, you can follow the same format. Now, any patient or any child coming to you with acute vomiting, you need to make sure you reassure the parents. You need to make sure you ask the hemodynamic stability from the examiner. So how you'll start, so in here, there will be no children or no neonate in your station. There will be parents over there who will talk with you. And you will just pretend that, yes, the child is there, but there will be no one normally. So you will start in this way. Hi, John, this is Dr. Arshan, one of the doctor here. I understand that you must be really worried about your child because I read from the notes that your child has been vomiting lately. I'm really sorry to hear that, but please don't worry. Now that you are here, your child will be taken care of by our team of members, and we will make sure your child gets comfortable like before. Before I start asking question to you, I want to make sure your child is stable enough to go for further history. Please excuse me for a moment. I will talk with my examiner and I will come back to you. So dear examiner, I would like to know if my patient is vitally stable for further history. And I would also like to know if there is any sign of dehydration. See that I added this particular part in here, that is there any sign of dehydration, because children, rather than asking the vitals, best thing to assess fluid status in a child is the dehydration status. So always ask at the first that if there is any sign of dehydration. Now if there is mild or no sign of dehydration, you don't need to do anything. Even moderate, we don't need to do anything. We can ask the question and then manage. But if it's a severely dehydrated child, then you have to start IV fluid. Clear? After finishing that, you will come back to the patient, parents and say, thank you so much, John, for waiting for me. Now, would you mind telling me what exactly happened? So then they will say, doctor, just suddenly he has started vomiting, or sometimes they can say he has been vomiting for the last 2 weeks and it's getting worse. So any of these, they can give it to you. Now you need to ask the detailed question of vomiting. What is the detailed question of vomiting? First of all, since when? If they don't give you a time duration, then you have to ask since when he has been vomiting, how many episodes in a day. Now, for any discharge, for anything coming out of the body, we use a term called CCVO. CCVO is the color, consistency, volume, and odor. So you can ask in the same mnemonic. So what's the color of the vomiting? Have you noticed any blood in it? Is it, and consistency means like, is it thick or thin? For vomiting, consistency is not very important. You can ask like, what was the content of the vomitus? Like what exactly came out? Is it the food? Is it just the breast milk? So what is the content of the vomitus? You can ask. Was it profuse or small in amount? So we need to find out the volume, small or large in amount. And is it foul smelly or not? So this is called CCVO. So what is the color of the vomitus? Any blood in it? What was the content of the vomitus? Was it small or large in amount? And is it foul smelly or not? Now for vomiting, we need to ask these questions. These are very important and it can even give you the diagnosis. So is it a forceful or projectile vomiting? Forceful projectile vomiting is more common in pyloric stenosis. So that's why we ask it. So is it forceful or projectile? Then is there any relationship of the vomiting with the feeding? If yes, then how soon after feeding does he vomit? Children with pyloric stenosis, just after taking food or just after breastfeeding, they will vomit. Okay, so that's why we need to ask it. And do you think he is hungry or he cries in between the feeding? So Usually pyloric stenosis child, they vomit whatever you give it to the child, and they feel hungry just after the feeding, because whatever you feed, it's been vomited out. So they will feel hungry. So these are the questions you need to ask. So since when, how many episodes so far, or how many episodes in a day if it's going on for few weeks? What's the color of the vomiters? Any blood in it? What was the content of the vomiters? Is it small or large in amount? Is it foul smelly? Is it forceful projectile? Any relationship of the vomiting to the feeding? If yes, then how long or how soon after the feeding does he vomit? And is he hungry after the feeding? After you have asked the vomiting question, which is your history of presenting complaint, after you have asked that, then you ask about the associated symptoms. What is the associated symptoms with vomiting? So along with the vomiting, have you noticed any swelling or distension of the tummy? Any lump or bump in the tummy or in the groin? Why we are asking that? That lump in the tummy, sometimes, if it's a pyloric stenosis, you can feel a lump in the tummy. If it's the intussusception, you can feel some lump in the tummy. And in the groin, lump is very important for incarcerated hernia or any hernia that can also cause vomiting. And we can find some lump. So associated symptoms we need to find out. Very, very important. So along with the vomiting, have you noticed any swelling or distension of the tummy? Any lump or bump in the tummy or in the groin? Now remember, if you forget to ask this associated symptom, you can always ask it in the differential diagnosis, because these are our differential also. Like lump in the tummy or groin. Groin lump is for hernia. So you can ask it during asking the differential diagnosis also. So it's not very important to ask like that. Now, the differential diagnosis is the most important one. And you have to ask a lot of DD, because usually they usually ask you the differential diagnosis in here. So in case of differential diagnosis, what you are going to ask, first of all, is start what I used to do, that I ask the vomiting first. After asking the vomiting, then I ask for bowel habit, bladder habit, because you cannot ask tummy pain in a child, because they will not be able to say, right? So don't ask tummy pain if they are like a 6 weeks child having vomiting. If you ask, is there any pain in the tummy? That sounds silly. So don't ask that. So for in what you should ask, first ask the vomiting questions, then ask about bowel habit, ask about bladder habit, then you go into the other differential diagnosis. In that way, it becomes more easier. So in case of differential diagnosis, start with the bowel habit, which will rule out your one of the important DD, intestinal obstruction. So how about his bowel habit? When was the last time he passed the stool? Any history of diarrhea or constipation? Okay, so for intestinal obstruction, we ask that. How about the bowel habit? When was the last time he passed the stool? That's for, because in case of intestinal obstruction, patient will say that like he hasn't passed the stool so far for the last 2 days or for the last 1 week. So very important to ask about the bowel habit. When was the last time he passed the stool? Now in here, if you forget to ask about tummy distension or swelling, you can ask it here. So you can ask any swelling or distension of the tummy, any history of diarrhea or constipation. Then for the urinary tract infection, how about his waterworks? Have you noticed any change in color or smell of the urine? Any change in number of wet nappies? And does he cry while passing the urine? Now, you are ruling out two things by asking the waterworks. One, that you are ruling out urinary tract infection. Another, you are also finding out if there is any dehydration. So for UTI, you ask how about his water works, any change in color or smell of the urine, does he cry while passing the urine? And also, if it is a dehydration, then we ask it that is there any change in number of wet nappies? Okay, so any change in number of wet nappies is important to ask. Why? Because the patients who are having dehydration, or the children who are having dehydration, the number of wet nappies will be reduced. This is a very important sign that you can understand that this child is having dehydration or not. Okay, so ask about the intestinal obstruction, ask about the UTI. This is very important. Remember, UTI many times presents with vomiting. Clear? So we ask about the intestinal obstruction, we ask about the UTI. Now for the intussusception, what you want to ask? So in intussusception, also child can present to you with vomiting. Now, normally the question for your intussusception is that does he draw up his legs while crying? And does he turn pale while crying? So children with intussusception, they will have a lot of pain which comes on and off. So whenever their pain will come, they will draw up their leg to their chest as if they are in a severe pain. So does he draw up his legs up to the chest while crying? And does he turn pale while crying? Okay. So that's your intussusception. Then come to the other non-infectious causes. Sorry, infectious causes. So what are the infectious causes we have got? So for septicemia or meningitis, any fever, any rash. For otitis media, any discharge from the ear, any pulling of the ear. Children having otitis media, they cannot complain ear pain, but you will find out they are pulling their ear. So that pulling ears actually a sign that they are in a severe pain. For pneumonia, is there any cough, shortness of breath? Now, look at this thing. We have asked most of our differential diagnosis just by asking those differential. One of them, pyloric stenosis, the vomiting will be forceful projectile soon after the feeding, and it usually comes in 2 to 6 weeks after the birth. Okay, and for pyloric stenosis, child usually lose their body weight. This is one of the very important finding. For duodenal atresia, it depends on mainly duodenal atresia children will come or presents with vomiting just after the birth. So soon after the birth, if the child starts vomiting, that's duodenal atresia. Gastroesophageal reflux can happen anytime, but they can have vomiting. Sometimes even they can be projectile vomiting, but they will not lose body weight. They will thrive well and they will grow well. So that's important for gastroesophageal reflux. Okay, so there is no specific question for these three differentials. Just asking the vomiting question will help us to find it out. For incarcerated hernia, we already asked, have you noticed any lump in the tummy? If there is a lump in the tummy, then we would think about hernia. For intussusception, we asking the question, does he drop the leg up to the chest while crying? Does he turn pale while crying? Sometimes you can also ask any loose stool, which is like kind of red currant jelly-like stool. Intestinal obstruction, you ask the bowel habit and when was the last time he passed his stool. Gastroenteritis, you ask about diarrhea, you ask about vomiting, so that will cover it. You ask about fever also. For non-GI causes, you ruled out UTI by asking water works, any change in color or smell of the urine, does he cry while passing the urine? These are all UTI questions. You ask about otitis media, you ask about meningitis by asking fever rash, you asked pneumonia by asking cough, shortness of breath. For torsion of the testes, there is nothing to ask. We can do some physical examination from examiner, then we can rule this out. Clear? So this is how we are ruling out the differentials. So history will cover the vomiting question. Very important to ask these questions. Then we go for the differentials. You can ask intestinal bowel habit, waterworks, intussusception, okay, and then also incarcerated hernia. After that, we ask the infectious causes, which is meningitis or septicemia, otitis media, pneumonia. So that's your DD. Now, there are in every pediatric cases, we ask these questions. What are those questions? There is a well baby question, binds, TMAC, past medical history, family history. Now, in this cluster, we don't have the broad note about this one. In our chronic cough cluster, we have the broad note about this well baby binds and everything. When you will do the cough cluster, you will get the note of this well baby questionnaires and everything. But tonight, I will just discuss what you can ask in the well baby question. In well baby question, there are four things we normally ask. One, that is he, that means the mental status of the child. So is he active, alert, or drowsy? So that's one question, mental status. How about his feeding and sleeping? Now, already you know he's been vomiting. So obviously feeding is not good. So not very important to ask. So in other cases, we might ask, how about his feeding and sleeping? But in here, not important. Number three is for bowel habit. That means pee and poo. How about his pee? How about the poo? Now you already asked the UTI question. You already asked the bowel habit question. So even you don't need to ask it here. So only thing in well baby question for this particular cluster is is he active, alert, or drowsy? That's only one question. You don't need to ask about feeding and sleeping or pee and poo. After well baby question, then we have binds. Bind will cover some of the important aspect of pediatric history. One is B for birth history, I for immunization, N for mainly nutrition, not very important to ask, D for development of the child, and S for social history. Okay, so birth history. For a child with vomiting, birth history is very important. So for in here, you will ask, how was the birth of the baby? Was there any complication before, during, or after delivery? Okay, or you can ask, how was the pregnancy? Was it uneventful? Is there any complication during pregnancy or after delivery of the baby? That's your birth history. Birth history can be a broad history, but for vomiting cluster, only one question. So how was the birth of the baby? Was there any complication during or after delivery? And then for immunization, in immunization, you ask, is he immunologically up to date? Sometimes they may not understand what is immunologically up to date. Then you will say, how is how was the vaccination schedule? Is he up to date with the vaccination? Okay, or you can just ask one question, is he up to date with the vaccination? Or if you ask it, so you can ask it, is he immunologically up to date? Sometimes they also understand that. That's for immunization. Nutrition, no need to ask it. Development. Developmental question is important. How about his growth and development? Just one question. How about his growth and development? And lastly, social history. Social history is not very important for this sort of child, like who is 6 weeks, 8 weeks, 10 weeks. Not very important. Social history is more important in case of older children. Okay, but in here we don't need to ask it. Now you can keep sibling for S, but again sibling history is not very important for this cluster. Okay, so we'll just keep the from the binds. We will ask like, remember, you may not have enough time to finish it, so don't ask too many questions, just the important question. So how about the birth of the baby? Was there any complication? You can ask, like, sometimes premature baby tends to get the sort of complications, so you can ask, was he a term or a preterm baby? That one question is important to ask. So normally in birth history, we ask a lot of questions, but in this cluster, we will just ask, how was the birth of the baby? Was there any complication? Is he a term or preterm baby? Then is he immunologically up to date, or is the vaccination up to date? How about his growth and development? That's that only three things you will ask. No need to ask nutrition, no need to ask social history. Then TMAC. TMAC will cover, in case of mainly infectious causes, TMAC covers many things. One, T for travel history, M for medication, A for allergy, and C for contact history. Okay, so travel history, medication history, allergy history, contact history. Now, for a vomiting cluster, these are not very, very important, but you can ask. So, any recent travel history, is he on any kind of medication, any history of allergy, any contact with someone having the similar complaint? Just in one go, you can ask it if you have a lot of time. Otherwise, TMAC is not very important for this particular cluster. But otherwise, in some of the cluster, like cough cluster, it will be important. So, is there any recent travel? Is he on any medication? Any history of allergy? Any contact with someone having the similar complaint? That's your TMAC. Then any past medical history, any family history of vomiting disorder. Clear? So this is how you will finish your pediatric history. Any pediatric history will be finished with these five things. Well baby question, binds, that means relevant binds, not everything. Relevant binds, relevant TMAC, past medical history, family history. So any pediatrics, the format in your mind should be in this way. So first I will reassure the parent, then I will ask the HOPC, which is the presenting complaint. So in here it is vomiting. Then I will ask associated symptoms. Even if I forget it, I will ask the differential diagnosis. All the differential diagnosis I will ask one by one. So for vomiting cluster, I will start with the bowel habit, waterworks, intussusception, and incarcerated hernia. And then I will ask the infectious causes, UTI, already I asked it. Then I will ask pneumonia, otitis media, meningitis. Then I will ask well baby, binds, TMAC, past medical history, family history. So remember, once you will adapt with this format, it will become really easier to ask any pediatric question. Any questions so far, guys? So this is your history for pediatric vomiting cluster. Now we will move into all our cases related to vomiting. But before that, any one of you having any questions? Good, clear? Those who are in the Facebook, you guys can hear me, right? Please remember, the next session we will take the role play session. Try to come into the Zoom, because then you guys can interact with me with the role play session. Okay, let's move on. I guess there is no question. Now, the next one is the urinary tract infection. So for urinary tract infection, we have got a case that mother came with a 9-month-old female baby with fever and vomiting for the last 2 days. And you are a GP. So the question will be like, you have got a patient or the mother of a 9-month-old baby came to your GP clinic because the baby has having this fever and vomiting for the last 2 days. You need to take a history, physical examination from examiner, diagnosis, further management. All right. So Dr. Kuku, thank you for asking the question. Now, remember, like in the exam, this is very common that you may run out of time. In that case, if you skip these things like TMAC, past history, family history, it will not cause any trouble. Okay. If you can ask the differential diagnosis and the vomiting question lot better way, then they usually don't bother you asking past medical and family history. Clear? Sorry, I think I'll just make it like this so that you can find it out. So now the history. Already you know how to take a history for vomiting. Now in here also you've got fever as a presenting complaint. So again, you greet yourself, then you reassure the mother that your baby is going to be fine, please don't worry. Then obviously make sure that child is vitally stable and having no sign of dehydration. Then after that, you will start with the presenting complaint, which is the fever and vomiting. So for fever, you can ask that since when he is having fever, is it continuous or on and off? Any chills or shivering? Did you measure the temperature? Have you given any medication? Just 5 questions. Since when? Continuous or on and off? Any chills or shivering? Did you measure the temperature? And have you used or have you given any medication? Then vomiting question, CCVO, and then also those 3 questions, projectile or forceful, and also any relationship with the feeding, how soon after feeding the vomiting comes, and also like does the child cry soon after feeding? After vomiting question, then we ask all the differential diagnosis. Now in here, which question will come first? GIT causes or the non-GIT causes? In here, the non-GIT causes will come first because you have got fever and vomiting. So start with the infectious causes first. So what are the infectious causes of fever and vomiting? UTI, gastro, then you have pneumonia, otitis media, and also meningitis or septicemia, right? So these are your main DD. So you will start with the fever and vomiting. So infectious causes will come first. So start with the head to toe fever source question. Now, when I say head to toe fever source question, I will use this term throughout our 5-month session. Those who will join the session, you will know we have to always use the same thing. So any patient having fever, we always ask head to toe fever source question. So from the head, which one will come with meningitis? So for meningitis, we need to ask any rash, any complaint of neck pain or neck stiffness. Now, for a child with a 9-month, they don't complain neck pain, neck stiffness, so don't ask it. So only relevant question for a child with a 9-month-old, there will be fever, vomiting, and rash in the body. Fever, vomiting already been asked. So only thing you will ask here is any rash in the body. Just one question. For otitis media, any ear discharge, any pulling of the ear. Viral RTI, you can ask. For upper respiratory tract infection, we ask any runny nose, sneezing, any itching of the eyes. Have you noticed or not? Mainly runny nose is very important to rule out viral RTI. For now, see that we are going from head to toe. We started with the head, then in the ear, then the whole upper respiratory tract infection, now the lower respiratory tract, which is the pneumonia. So any cough, any shortness of breath. Then go down, you have the tummy. In the tummy, you have gastroenteritis and UTI. So ask about the bowel habit, ask about the waterworks. Cool. So these are the main differential diagnosis of fever and vomiting. So meningitis, otitis media, viral upper respiratory tract infection, pneumonia, gastroenteritis, UTI. After you have asked those questions, just ask a couple of GIT differentials, which normally we would ask at first, but in here we will ask it later on. So ask about hernia intussusception. You already asked about pyloric stenosis and reflux just by asking vomiting question. See that how format helps us to find out a case. So in this way we will ask, okay? So fever question, then the vomiting question, and then we ask the relevant differential diagnosis. So meningitis, otitis media, viral upper respiratory tract infection, pneumonia, gastro, UTI. Then other GIT question also important. Incarcerated hernia intussusception, pyloric stenosis, gastroesophageal reflux. After that, start with the well baby question, binds, past medical history, and family history. Okay, so this is how you will finish it. Now in here, past medical history relevant to ask any past history of kidney disease and any previous history of urinary infection. So previous or past medical history of UTI is important, and also family history of any kidney disease also important. So this is mainly your history. See that we don't need to discuss it again because we already know a format. Then in the PFE, what you need to ask, in every vomiting cluster, we can follow the same thing. So start with the general appearance. So when you finish a history, thank the mother and then say that, thank you, Sarah, for asking all my questions. Now, please excuse me for a moment. I would like to talk with my examiner and come back to you. So examiner, I would like to know the general appearance of the child. Is he active, alert, or drowsy? Is there any dysmorphic sign of Down syndrome? And in here, we don't need to ask whole pickled. We will ask only dehydration. If you haven't asked it at first, then at least ask it here. So is there any sign of dehydration? Then also, because we are ruling out meningitis, so we need to ask about any rash, any skin pigmentation. Skin pigmentation, not very important. It's a case with congenital adrenal hyperplasia. They can also present to you with vomiting. Then we ask about skin pigmentation, but not very important case. So for general appearance, there is a lot of things to ask in vomiting cluster. So start in this way on general appearance. Is the child active, alert, or drowsy? Is there any dysmorphic sign of Down syndrome? Any sign of dehydration? Any rash? Any skin pigmentation? This is all in the general appearance. After that, if you haven't asked the vitals, or even if you ask vitals, then you can ask that, is the vitals same like before? Or if you forgot to ask vitals, then in here you will ask it again. Any pediatric cases, growth chart is a must to ask. If you don't ask growth chart, your missing one key step. Okay, so growth chart, you will ask in this way, is the growth chart available? And if available, then the examiner will give you the growth chart value. They can say, well, the child growth is in between the 50th percentile. So anything between third and 97th percentile is normal. So just ask, is their growth chart available? Now, remember, we are ruling out some of the DD also. So in the PEFE, ask about ENT examination. We need to also ask about neck stiffness. So how you are asking this question from the examiner? So first of all, you will ask the general appearance, and then, doctor, I would like to know the vitals, pulse and blood pressure, temperature, respiratory rate, and oxygen saturation. Is the growth chart available? Then I would like to start with the ear, nose, and throat examination. In ENT examination, I'm not going to do the detailed ENT examination today because we will do that in our respiratory cluster. Just to remember, in ENT, just one question. In the ear, any discharge, any tympanic membrane changes. In the nose, any nasal discharge, any nasal mucosal changes. In the throat, any tonsillar hypertrophy or exudate. Just 3 questions for ENT. Again, in the ear, so I would like to start my examination with ear, nose, and throat examination. In the ear, is there any discharge, any tympanic membrane changes? In the nose, any nasal discharge, any nasal mucosal changes? In the throat, is there any tonsillar hypertrophy? Is there any exudate? Is there any neck stiffness? Very important. Any child having vomiting, if you don't ask neck stiffness, if you don't ask rash, these are also missing the key steps. Then systemic examination, what you want to do? You will say, I would like to do the head to toe systemic examination, but I would like to focus on abdomen. On inspection, is there any visible distension, any visible peristalsis or mass? On palpation, is there any palpable mass, any tenderness? On auscultation, is the bowel sound audible? So just this abdomen should be done in detail in case of vomiting cluster. So on inspection, is there any visible distension, any visible peristalsis or mass? On palpation, is there any palpable mass, any tenderness? On auscultation, is the bowel sound audible? Then, with the consent of the parent, I would like to check the hernial orifice, genitalia, and also the paranal inspection. Now, paranal inspection is not very important for vomiting cluster, but for vomiting cluster, important is to check the hernial orifice is very important, very. So that's why I'm saying is very important. Sometimes when you ask, is there any, have you noticed any lump in the groin? Mother or father will say no. Maybe they haven't noticed it. But when you ask about a hernial orifice, examiner will give you a picture showing incarcerated hernia. So if you don't ask it, you just miss the total case. Okay, so ask about the hernial orifice, then genitalia, mainly for ruling out torsion of the testis. And then you will say, I would also like to finish all other systemic examination, including respiratory, cardiovascular, abdomen. Normally, examiner will say those are normal. And any physical examination, we finish with office test. So ask about, is there any office test available? Like urine depistic. Mainly for child, urine depistic is important because we can ask about the leukocyte and nitrite. Sometimes if you just say urine depistic, examiner can say what you are looking for. So you will say, I'm looking for any leukocyte, nitrite, or RBC. So this is our PEFE, right? So general appearance, vitals, growth chart, ENT examination, neck stiffness, In systemic examination, focused abdominal exam, and then other system in one go, and office test. Remember, guys, I have seen a lot of candidates who start with the CNS, then chest, then CVS, then abdomen, like in a systemic way. But no, in these cases, you don't have that much time. You will do focused examination, which is relevant for vomiting. Our main systemic examination will be focused on abdomen and also ENT. Other than this, others are not very important for us. Now, explain and management of UTI. In urinary tract infection case, the only thing positive will be child will have fever and vomiting. And in the urine dipstick, they will give you leukocyte nitrite. And sometimes when you ask about urinary tract infection questions, they can give you, yes, there is some strong odor or change in color or smell of the urine, or the child cries while passing the urine. So these are the important things you can find out here. For management, what you say that, well, from the history and physical examination, most likely your child is having a condition called urinary tract infection. Do you know what it is? No, doctor. Well, it's the infection of the urinary tract caused by a bug. Now, let me draw a picture for you better understanding. So, draw a picture of the whole urinary system. So, how you will draw it? Just very fast, okay? You don't have that much time in the exam. Very fast, draw it, and then say it's an infection of the urinary tract caused by a bug. Let me draw a picture for your better understanding. So this is the kidney, and from the kidney, then the water comes through a tube-like structure into the water bag called ureter, and then it passes out through the water tube outside the body. Now, the outside tract is very close to the back passes, and bugs can easily enter into the urinary tract, and then it can cause infection and inflammation, which later on manifest as fever, vomiting, and painful smelly urination, just like in your child. Okay, so in this way you will draw a pictures and then say it's an infection of the urinary tract caused by a bug. This is the urinary tract starting from the kidney, ureter, bladder, and then a water tube from which the urine comes out. Now this the external or outer tract is very close to the back passes. So bugs from the back passes can easily enter into the urinary tract, and then later on it can cause infection and inflammation. As your child is still 6 months old and is considered to be a part of vulnerable group of patient, I would like to send your child to the hospital. In the hospital, she will be seen by a child specialist for further evaluation and management. Now, urinary tract infection in below 1 year old, that's always you need to send them to the hospital for further evaluation and management. Because less than 1 year old child, they are vulnerable, they are high risk patients. What if it can turn into a sepsis later on? So that's why. So first of all, is explain what is urinary tract infection, and then send the patient or send the child to the hospital for further evaluation and management. And now, remember, sometimes they can ask you only differential diagnosis, sometimes they can ask you diagnosis and management. If management is a task, then the whole management of UTI, you have to talk in a little, like in little detail. Otherwise, if differential diagnosis is a case, then you will just start with the differential diagnosis after explaining the condition. Now, if it was a case of differentials, then how would you do that? You would say most likely your child is having a condition called urinary tract infection. Do you know what it is? No, doctor. Well, it's the infection of the urinary tract caused by a bug. Let me draw a picture for a better understanding. This is the urinary tract starting from the kidney. Then there is a long tube called ureter that brings the urine to your water bag, and then it comes out through the water tube. Now, this water tube can be very close to the back passes, so the bugs can easily enter into the urinary tract, causing infection and inflammation. And that actually manifests as a fever, vomiting, and painful, smelly urination, just like your child is having. Please don't worry, it's not a serious condition, but obviously we need to manage this as appropriately as needed. Now, this can be due to other causes as well, like it could be due to infection of the meninges called meningitis, but your child doesn't have any rash. Okay, so it's unlikely. It can be due to pneumonia or chest infection, but your child doesn't have cough or shortness of breath. It can be gastroenteritis, which is infection or inflammation of the gut, but your child is not having any diarrhea. It could be otitis media, which is infection of the ear, but your child is not having ear discharge and also no pooling of the ear. Could be due to other causes related to the gut, like it could be pyloric stenosis, but your child doesn't have forceful vomiting and your child is not losing body weight, so it's unlikely. It could be intussusception, but your child is not drawing up the legs up to the chest during crying, and he's not having a on and off episodic crying as well, so it's unlikely. It could be intestinal obstruction, but your child bowel habit is regular, so it's unlikely as well. So this is how always you need to explain the differential diagnosis. Now, if DD is not a task, even when you finish with your explanation of the diagnosis, give some DD always, even if it's not your task, because that actually is a very good way to finish a case. So if management is a task, then what you can do after explaining it, you can just say, that, well, it could be due to other causes like meningitis, pneumonia, septicemia, gastroenteritis. But in your child case, I don't think these are the possibility. Just in one go, you can just say some of the DD. You don't need to even explain it because you need to explain the management. Now, in the management part, you are a GP setting, so you need to send this child to the hospital for further evaluation and management. In the hospital, she will be seen by a child specialist. Any child who is less than 12-month old, just a urine dipstick cannot confirm UTI. So we need the suprapubic aspiration. So you would say, as the initial urine dipstick is just a screening test for the infection, most likely in the hospital, they might take another urine sample, probably by a method called suprapubic aspiration, and send the urine for culture to confirm the diagnosis. In this procedure, a needle will be inserted just below her umbilicus and a sample of urine will be collected from there. Please don't worry, it will be totally pain-free and will be done by a very experienced doctor. Always give some hope to the patient. Are you with me so far? Yes, doctor. Well, after confirming the diagnosis, then the specialist might also put your child on antibiotics to fight the infection and Panadol to address the fever. So this is the main treatment, giving the antibiotic. They may also decide to do some more imaging to find out the cause of urinary tract infection in your child. Like they might decide to do an ultrasonogram of our waterwork system to exclude any structural abnormality causing this infection. In some children, those who have recurrent infection, specialists might also do another test called micturating cystourethrogram, where a special dye will be inserted into the urinary tract to look for any abnormality. But all this will be decided by the specialist. Now, this is an important part of management. You have to address that if management is a task. So you have to say that it's not for this child. A specialist might consider to doing an ultrasound of the urinary tract to exclude any structural abnormality. Also, sometimes a specialist might do another special test called micturating cystourethrogram, where a special dye will be inserted into the urinary tract to look for any abnormality. Then after that, just say, please don't worry. Most of the children with urinary tract infection make a good recovery and have no future problem. Once you are discharged from the hospital, I will again review your child and always try to maintain the hygiene. So try to wipe from front to back and give your child ample amount of fluid to take. I will give you some reading materials to read it during your during sending to the hospital or also in the hospital. Anytime after the discharge, your child having the similar complaint, please bring her back to me or go to the emergency department. Are you having any more questions? You can ask me at any time. So this is how you will finish. Always finish with the 4R, right? So you have given reading materials. You said that you will review after she discharged from the hospital. Then also you already referred to the hospital. Okay. So review, reading materials, refer, and red flag. These 4 are how we finish a case. Clear, guys? So this is the management of UTI. So always start in this way. Send the child to the hospital if it's a GP setting. Then say that she will be admitted to the hospital, seen by the child specialist. They might do the suprapubic aspiration. They will start with antibiotics. They might do some more imaging. One is ultrasound, another is micturating cystourethrogram. Remember, when you use a term, medical term like this, always explain what it is. Okay, that's very important to explain. And then just give some reassurance, hygiene advice, and finish with 4R. Okay, that's very important. Any question from the UTI? So Dr. Shaila, if it's a 3 or 4 year old, then you don't need to do the suprapubic aspiration. 3 or 4 year old, we can just do the normal midstream urine, or we can use it from a catheter sample. It's just mainly for less than 12-year-old, we need to do the suprapubic aspiration. But for more than 12 year, even urine dipstick is okay. After urine dipstick, we can just send it to the microscopy and culture. Yeah, so suprapubic aspiration before 12 months. Any question, guys? So if severely dehydrated, you have to give IV fluid. No, we don't need to mention the name of the antibiotics. That's a good thing about the AMC, that you just say that a specialist will give antibiotics. We don't need to give the name of the antibiotics that we will give. Not important, even name or dose is not important. Just saying antibiotic is all that they want. Now, remember, Dr. Iappa, it depends on the level of dehydration that you will give NG tube or IV. In case of moderate dehydration, you will start with the NG tube hydration. If NG-tube hydration doesn't work, then you can proceed to the IV. For severe dehydration, you have to start with the IV fluid. Dr. Rizwana, very good question. Even the patient is 9 month old, do we still mention? Now you can mention it. Like for differential diagnosis, you can mention any differential, but you are not giving it as a diagnosis, right? So for differential, you need to show the logic that why it's not pyloric stenosis. Because yeah, this is also a logic that 9 month old having a pyloric stenosis is very unlikely. So in differential diagnosis, we can say any of the relevant DD, but we just need to say that why is not the diagnosis. Good. So after 1 year, yes, after 1 year, we can use like midstream urine, we can use the catheter sample, but we don't usually use the bag sample, bag specimen. Otherwise, we can use anything. Now, it depends that if the child is able to give midstream or not. If the child is not able, then we have to proceed for like in and out catheter, or we can do the suprapubic aspiration. Okay, but most of the time after 1 year, it will be it will be possible to get the urine from the child. Okay. Now also, if sometimes what you can say in these cases, Dr. Mukta, like after 1 year, usually after 4 year, midstream, like 3 to 4 year, midstream urine becomes more applicable, because at that time, child usually will be able to give you a midstream sample. But in between like 1 to 4 or 1 to 3 year, we can use some other things, like we have clean catch urine. Okay, like clean catch urine is good one. Sometimes we have in and out catheter, so insert the catheter, get the urine, and then out the catheter. So these two are also an option for 1 to 3 year old child, but bag specimen is not a good one. So you can keep it in this way: midstream urine for 3 to 4 year old child. Less than 1 year, we use obviously suprapubic aspiration. Between 1 year to 3 year, you can go for clean catch urine or in and out catheterization. If that is not possible, then you can go for suprapubic aspiration. Yes, investigate for this sort of children. We will always do the investigation to find out why they are getting the infection. Mainly for recurrent infection, it's more indicated to do this ultrasound and MCUG. But obviously, in case of AMC, you will say that these are the investigations we can do to find out any underlying cause. But it will depend that if the specialist wants to do it now or wants to do if there is any further infection happens. But it's for any older like for children, we usually do these underlying imaging investigations. And admission, Dr. Faiz, like it depends on many things. Usually if it's a UTI child, send to the hospital always. Okay, sent to the hospital, seen by the specialist. If they think that this patient doesn't need to be admitted, they will discharge the child. Okay, but don't just give some antibiotics from the GP setting and then send the child to the home. Usually it's always try to be safe in AMC. Normally we do many things, but in AMC exam, always be safe, doctor. Send the child to the hospital for further assessment, because there will be a pediatrist, like pediatrician will be there, right? And pediatrician can do further investigations, or if he thinks that this patient doesn't need to be investigated, then he can discharge the child. But you are being a safe doctor. Okay, let's move on. Next one is gastroesophageal reflux. For gastroesophageal reflux, you have found you are a GP and a mother brought her 4-month-old baby girl. She says the child vomits after feeding. There are no other symptoms. Mom thinks that bottle feeding will be better for him. History, PAFE, diagnosis and management. So you have got a child who is 4-month-old and vomiting after feeding. So again, go for the all question. Now in here, I'm not going to discuss the history again because we already know what are the history we are going to ask. So in the history, mainly what you will get in gastroesophageal reflux disease is that child will have vomiting after feeding. Most of the time, those are not forceful or projectile, but sometimes they can be forceful. Just because it's forceful, it doesn't mean it always pyloric stenosis. So that's obviously child will have vomiting after feeding, and child will grow as a normal child. That's the main point to differentiate it from the pyloric stenosis, that child will have normal growth. Okay, so child body weight is fine, growing and development fine, just vomiting after feeding, that's gastroesophageal reflux. In physical examination, you will get nothing. Okay, everything will be fine. But very important not to miss vital, not to miss growth chart in this case, because that will give you the idea that if it's a gastroesophageal reflux or pyloric stenosis. In the physical examination from examiner, nothing much to us. All the things that I have added in the urinary tract infection case, same you will ask in every vomiting cluster. But as the child doesn't have any fever, ENT examination is not very important in gastroesophageal reflux case. So after you have done the history and physical examination, you will find out that this child is only having vomiting after feeding, growing and developing well. So it's a gastroesophageal reflux. Now for gastroesophageal reflux, there is two terms which majority of the candidate get confused with. One term is called gastroesophageal reflux. Another term is called gastroesophageal reflux disorder or disease. Now, gastroesophageal reflux is a physiological thing. It happens to every child and nothing to worry about. But gastroesophageal reflux disease, it's the complicated form of reflux. So how you can find it out? Always in any child you think it's a reflux case, you have to rule out these red flags. One, if the child is having pronounced irritability with arcing of the back, if the child refusing to feed, any hematemesis, apnea, chronic cough, and if the child is not gaining enough weight. So main finding is this one, pronounced irritability with arcing of the back. This is the most important feature of gastroesophageal reflux disease. Other than this, always in the vomiting question we ask, is there any blood stain? So that will cover it. We ask cough question, so it will cover it. For apnea, you just need to add that anytime have you seen your child stop breathing for a few seconds? That's apnea. And refusing to feed, you are asking like, how is the child feeding and sleeping, right? So that's also will be covered in the well baby question. And just this one pronounced irritability with arcing of the back, this one you will ask in the general appearance of physical examination. So you will ask, is there any arcing of the back? Okay, so this is how you can rule out gastroesophageal reflux disease. It's very important to ask in the history, also in the PEFE. Apart from that, everything is same. So explain what is gastroesophageal reflux. Say, with the history and physical examination, I am suspecting your child most likely having a condition called gastroesophageal reflux. Do you know what it is? No, doctor. Well, this is a condition which is characterized by passage of content of the stomach into the food pipe. Let me draw a picture for your better understanding. So you will say most likely your child is having a condition called gastroesophageal reflux. Do you know what it is? No, doctor. Well, this is a condition characterized by passing of stomach content into the food pipe. Let me draw a picture for your better understanding. So you will draw the esophagus and draw the, oh my God, what's happening? Sorry. So draw the esophagus very quickly. You don't need to draw very good. So then after you have drawn it, then you will say, well, this is your food pipe, or you can say this is your child food pipe and this is the stomach. The lower part of the food pipe where it connects with the stomach is poorly developed in any child. And there's the reason why the milk in the stomach flows back into his mouth when you put him down. And that comes as a vomiting in your child case. So the lower part of the food pipe where it connects to the stomach is poorly developed in any child. And that's the reason why the milk in the stomach flows back into the mouth when you put him down or when you feed him. And it's a very common situation. Please don't worry about it. It's a very common condition where the baby vomits after each feeding, but otherwise, baby thrives well, grows well. The condition gradually start to improve after the introduction of solid in 4 to 6 months of age, and majority of the cases, it totally clears up by the age of 12 months. Now, it could be due to other causes as well, like then give the some of the differential diagnosis. Now, for the management of gastroesophageal reflux, main management is just changing the content of the food. So you can say that for the management, we don't need to give any medications for this. What I would recommend you to give him small frequent feeding, decrease the duration of feeding along with time in between. And the best thing is to try to thicken the feed with some thickeners called Gaviscon. Also, you can elevate the head of the cot by 10 to 20 degrees. After each feeding, please don't put your baby immediately to sleep. Carry him for a while and put him in cot with head elevated after 10 to 20 minutes. We highly recommend breast milk because it is best for your baby. Now, if this maneuvers doesn't help your child in few weeks, then I will refer him to a gut specialist who might start on some acid suppression therapy. But most of the time, children usually don't need any medication. Please don't worry, as long as your child is growing well, feeding well, there is nothing to be afraid of. I will regularly review him and give you reading materials. If you notice that your child is getting very irritable with arcing of the back, refusing to take any food, losing weight, having cough or some musical sound from the chest, or stopping breathing for a few seconds, please come back to me immediately. So this red flag is for gastroesophageal reflux disease. Okay. So this is very important to give it in this case. So gastroesophageal reflux is not very hard. It's very easy because only thing is child will vomiting after feeding and child will growing well, thriving well, everything is good. Just the vomiting is the issue. Clear guys? Any question? Okay. Now we'll take a 10-minute break now. And after that, we'll try to finish as much as case as possible tonight. So we have pyloric stenosis, then we have intussusception, then we have incarcerated hernia, duodenal atracia, and that will be the finishing. So 4 more cages are left. So we'll try to finish those cages. If anything we cannot finish tonight, we will finish in the next session with the role play session. But we'll try our best to finish it tonight. Okay, so let's take a 10-minute break. Now you know the cluster at the moment. After the break, I can go faster. Okay, so 10 minutes and then we will start it again. Thank you all. All right, guys, so let's start now again. So, next case is our pyloric stenosis. Now, pyloric stenosis is very important for your exam. So, you are an HMO in the emergency, 6-week-old baby presents with the father or mother with vomiting. So normally, as I said, usually 2 to 6 weeks aged group having vomiting, which is more forceful, projectile. That's most of the time pyloric stenosis. And also pyloric stenosis child will get severely dehydrated. They will also lose body weight. These are important findings you should always think about. For pyloric stenosis, what are the positive findings in the history? One, it could be that yes, 2 to 6 weeks of age. Vomiting, it will be non-bilious. That means whitish vomiting, whatever the child is eating, that means mainly the breast milk that will come out. So it's not bilious. Bilious vomiting means that anything in the duodenum, that means anything after the stomach, if there is any obstruction like duodenal atracia, or if there is intestinal obstruction, that will come as a bilious vomiting. So pyloric stenosis, it's a non-bilious vomiting. Progressively, it will become more forceful and more projectile. Child will get hungry just after the feeding and loss of weight. That's a very, very important finding in here. Child might be dehydrated. In the physical examination, always look for gastric peristalsis. Usually, you can, if it's not always, but you can see sometimes that there is some waves of muscle contraction coming from the left upper quadrant to the right lower quadrant. So, okay, so this is the gastric peristalsis. Also try to feel for a pyloric mass, which is mainly found in the right upper quadrant. And also, if you do the feeding test, that means ask, like you will ask the mother to breastfeed, and you will see that soon after feeding, child is having a projectile vomiting. That's called feeding test positive. So on examination, you will mainly look for these things. Main is dehydration, very important not to miss this one. Gastric peristalsis in the inspection, in the palpation pyloric mass, and also positive feeding test, you will ask it. Okay, so remember these important findings because these are the things will lead you to diagnose this case. So history is totally same like vomiting cluster, the history. In physical examination, just to add this thing, like when you do the abdominal inspection, ask for any visible peristalsis, any visible distension, any visible mass. And when you do the palpation, you will ask for, obviously we ask any palpable mass, any tenderness. And when you say palpable mass, sometimes they can give you, yes, you can feel a mass in the right upper quadrant. And also ask for a feeding test, that ask that is the feeding test positive or not. Now, when you get it, then you manage. So in the management, you will say most likely from the history and physical examination, your child is having a condition called pyloric stenosis. Do you know what it is? No, doctor. Well, let me draw a picture. So you will draw the picture from the food pipe, then the stomach, and then this the pylorus. So say that the milk goes from the mouth through a tube-like structure called food pipe to the stomach. From the stomach, milk then goes to the small gut. In pyloric stenosis, the lower end of the stomach, known as pylorus, get narrowed. And as a result of that, the milk or whatever your child is drinking cannot pass down to the small gut, and then the child vomits it out. And due to vomiting, he is losing fluid and he is losing salt and minerals from the body, and he is not gaining adequate body weight. This is an emergency condition, and most of the time an operation is needed to fix the problem. Please don't get stressed. I'm just saying the possibility, but it will depend on the specialist advice. Right now, what I'm going to do is to call an ambulance, arrange for the pediatric emergency retrieval team to take your child to the hospital as soon as possible. In the hospital, he will be seen by a child specialist for further management. Diagnosis is most of the time clinical, but they might do an ultrasound to confirm. They will also do frequent blood tests to check his salt and mineral levels, and also, if needed, they will replace it accordingly. Most of the child tends to get severely dehydrated in this situation, so in that case, they will also start him on IV fluid. Please do not feed him from now because he might need to be in the surgery. If your child keeps on vomiting, they might also insert a tiny plastic tube through his nose down to the stomach to remove any contents from the stomach, which we call NG tube insertion. Please don't worry, all these things will be painless. Your child will not feel anything. Once your child is stable, most likely they might decide to do an operation to fix this problem. Your child will be able to start eating and drinking usually 6 to 8 hours after the operation. Once the problem has been repaired by surgery, it is unusual to recur it or come back again. I understand that you were not expecting any of this, and I understand how much stressful it could be for you at the moment. But I want to assure you that your child is going to be fine, and we will do our best to manage his problem. But it's very important that you understand the situation, and then we will be able to manage your child problem, and we can make sure that he gets like a that he doesn't vomit like after every feeding like now. Once everything is done, once he's discharged from the hospital, I will again review your child in the GP clinic. I will give you some reading materials to read about this condition. Do you have any question? If you want me to call anyone, I will be happy to do that for you. Thank you. Okay, so this is how you do the management. Remember, see the ups and downs of my tone when I'm talking about the management is very important. A child 6 weeks old needs surgery is very much traumatic for any parents. Okay, so obviously you should give a lot of reassurance in here. One of the key step in here will be how reassuring you sound. So it's really important. Make sure you sound really absolutely empathic to the child, to the parents. Okay, now if you don't get enough time to do that, just in your mind you should remember what is the main management. Main thing is, you are a GP clinic, you need to send this child as soon as possible to the hospital. It could be air ambulance, it could be just roadside ambulance, whatever it is, send the child to the hospital first. Then this child needs to be resuscitated. So in the hospital, they will check the blood for salt and mineral levels. They will replace it. They will put him on IV fluid and nothing by mouth. And also they can do an ultrasound to confirm the diagnosis. And the most important is to talk about that operation will be needed to fix the problem. Don't need to say about the operation much. Just say that most likely this condition will need an operation to fix it. Okay, and if they want to know detail about the operation, say that, well, I'm a junior doctor. For the operation, the senior doctor or the pediatrician will discuss it in detail with you about the possibilities of the surgery. Okay, so but the basic thing is it's a pyloromyotomy in which the narrowed or stenosed pylorus will be open. So they will cut the excessive muscle which is causing the narrowing, and then again the opening will be intact. So this is the main thing. But otherwise, don't go into the detail about the operation in here. It's not your job. Your job is to just to say that what are the possible options of management this child have. Clear? So that's your pyloric stenosis. Any question, guys? Those who are in the Facebook, you guys have any question? Good. Now let's move into the intussusception, another important topic. So you are a HMO in the emergency, 5-month-old boy with multiple episodes of screaming for the last 6 hours, has been vomited twice in the last 3 hours. So 5-month-old boy brought in by father with multiple episodes of screaming. See, it's a episodic screaming or crying. That's one of the very important clue for intussusception. It will always be episodic, not constant. And also it will come very acutely, and vomiting also can be there. Management is same, sorry, task is same. So in this case, what you are going to do, you will say, obviously the same thing. So make sure you give proper reassurance to the mother, ask the hemodynamic stability. Everything is very important in here. And ask about the dehydration status. Then ask, after that, come back to the parent and say, can you please tell me more about it? Open-ending question. So then one by one, this is the screaming or crying episodes we need to ask in detail. So can you please tell me more about these screaming episodes? How long this is going on? How many episodes so far? Anything particularly happened before these episodes started? Is this continuous or on and off? Does he draw up the leg while crying? Does he turn pale while crying? These two questions are the vital questions for intussusception. So child usually drop the leg up to the chest and also sometimes can turn pale. Okay, so these are the presenting complaint you will ask. So since when this screaming episode started, anything particular happened, continuous or on and off, how many episodes so far, does he drop the leg while crying, does he turn pale? Then also your one of the other HOPC is vomiting, right? So ask the vomiting question just like we used to do. Then go to the differential diagnosis. So same things in here again, all the similar vomiting cluster question you will ask one by one. So intestinal obstruction, UTI, then also incarcerated hernia, then all the infectious causes we will ask one by one. For intussusception, you can also ask any loose stool or red colored stool. Many of the child with intussusception, they have a red currant like jelly, like red currant jelly like stool. That's one of the very important characteristic of this intussusception. You can ask it. And later on, you will finish with the well baby, BIMS, past medical and family history. PEFE, same like before, dehydration is very important, growth chart important. When you come to the abdominal examination, some of the important finding you can get in here. One, so you will do the inspection, obviously any visible distension, any peristaltic wave, any visible mass. Same thing for everyone. Now, with the palpation, sometimes you will be able to feel a sausage-shaped mass. So you will say on palpation, is there any palpable mass, any tenderness? If they says any palpable mass, yes, then you can ask that, well, is it a sausage shaped mass? So normally you may not get this mass to the every patient. If the child starts crying, sometimes you can feel it. So if you are totally sure that it is an intussusception case, then you can say that examiner says, no, there is no such a shaped mass. Then you can say, well, when the child cries, can I feel any mass? Then the examiner can say, yes, you can feel a mass when the child cries. That's one of the finding. Also, they usually have this empty feeling in the right iliac fossa. So you can ask it on palpation, is there any emptiness in the right iliac fossa? And is there any tenderness? Usually not very tender in here. On auscultation, how is the bowel sound? Sometimes you can get alternating high-pitched and absent bowel sound in this case. Okay, so mainly you are looking for a sausage-shaped mass and emptiness in the right iliac fossa in case of intussusception. Otherwise, everything is same. And also, obviously, you will ask for the hernial orifice. That's very important because you can rule out incarcerated hernia. And also, in this particular case, paranal inspection is very, very important because in paranal inspection, you can find the red currant jelly. There was a case in which they might put one dummy of a child, and they can ask you after taking the history from the parent, do the physical examination, and also do a rectal examination or like a genital examination or a paranal examination of the child. So when you do the paranal examination of the child, when you remove the diaper, you will find out the red currant jelly-like things coming out from the child parectal area. So that's one of the very important clue. Okay, so don't miss these things, guys. Okay, so parental inspection for any red currant jelly is very important in intussusception. These are key steps. Whenever I say don't miss it, make sure that these are very, very important and you don't want to miss it in the exam. So we already discussed the positive points. So patient will present to you with episodic crying, with drawing up the leg to the chest. During that time, child may look pale. You can get blood or mucus stained bowel motion with a classic red currant jelly. Sometimes diarrhea is also common, and sometimes intussusception can be there with a history of preceding upper respiratory tract illness. Not every time. Physical examination, we already discussed, not very important now. Now the management. How you are going to manage or explain intussusception is very important. So based on the history and physical examination, most likely your child is having a condition called intussusception. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So it's in a very easy way, you will draw like one gut going into the another gut. So you will say, so let's assume this is your gut. Okay, all right, or this is your child gut. In intussusception, there is sliding of one part of the gut into the other. And because of this sliding, the bowel or gut can get blocked or obstructed, which leads to severe pain and vomiting, just like in your child case. So it's very easily you are explaining. That's important. Okay, if you say invagination or invagination of one is like small gut into another gut, that's really patient will not understand anything. So always use a very simple word, sliding of one part of the gut into the another, making one gut blocked and obstructed, and that's why severe pain and vomiting. Now it is an emergency condition. Sorry, just give me a second. So it is an emergency condition. If it's a emergency setting, because you are in the ED, you can admit at this time. So it's an emergency situation. We need to admit your child and involve the child specialist as soon as possible. In the meantime, please do not give anything, any food or drink to your child. We will put an IV line and start him on IV fluid. Specialist might order some ultrasound and X-ray of the tummy to rule out any obstruction. So usually we do ultrasound and X-ray. Mainly ultrasound can confirm it. Once the diagnosis is confirmed, the treatment is usually given by the specialist, a radiologist, and a pediatric surgeon. They will possibly go for air enema, in which they usually pass a small tube into the back passage through which air will be passed to unblock or untwist the blocked gut. So usually what they do the air enema. In air enema, they pass a small tube at the back passes and then they insert or they pass air so that the sliding gut or blocked gut can get unblocked or untwisted. Please don't worry. Throughout the procedure, your child will be monitored by the specialist and he will be in sleep. He will not feel any pain. If this procedure is not effective, then surgery might be needed as well. Please don't worry. Now that you are here, we will give our best management to make him as comfortable as possible. Okay, give the mother a lot of reassurance. Say that I understand that you may not been thinking anything when you came here today. I cannot even imagine me in your place. I understand it must be very hard for you to get all these things now. But I want you to know that your child is with us and we will take the best care possible for him. When you say these things, mean it. Okay? It's not like just you are saying, mean it that you are actually will try your best. Like when I am saying it's, I'm meaning it. Say that, see that how I am saying, please don't worry. I understand that when you came here today, you may not think anything this will happen today. And I understand that should be really, really hard for you. But I want you to know that now that you are here, we will take the best care possible for your child. Your child is going to be fine. Please don't worry. If you want me to call any of your partner or friends or family, I would be happy to call them. If you have any questions, feel free to ask me anytime. I will be there to answer any of your questions. So your approach means everything, guys. I always say, like during the 5 month session, I will be saying it as much as possible that you will get it in your mind or in your brain. The approach will come. This is the main thing to pass the exam. Your approach, how you finish a case, which should have a lot of reassurance, means that you are going to pass the station or not. It's not just like asking appropriate question and just managing a child and then just finish the cases in time. It's not like that. One case, many candidate could pass it if they would pass in that way. And you do understand by looking at the exam results that very small number of people pass. Out of 32 or 36 students in one day, 4 or 5 will pass, others will fail. That's the truth. And from how you can get into that 4 or 5 candidates, just by your approach, nothing else. Many candidates know everything. Many candidates have a 10-year, 14-year experience. Even in Australia, they are doing a GP, but they need to do a MC clinical to, to go further, or to get permanent residency, or to get general registration. So they know all these things. Still, they fail the cases. Even Australian doctors, like doing 5 years, 10 years GP practice, they fail the AMC clinical. Why? Because of the approach. It's not like that everyone has it. It has to be grown into you. And Australia wants a better approachable doctor and a safe doctor to get into their system. Otherwise, many doctors have like a lot of knowledge. It's not only about the knowledge. You should really understand that and you should really work on these things. Cool. Sorry for all the advice. Once I start, I cannot finish like giving this important advice. Okay, now let's finish our intussusception. Then next one is incarcerated hernia. Incarcerated hernia, there are two possible cases. One, that child will come to you with the same feature of intussusception. That's why it's important not to miss hernia. Because see this question, 5-month-old baby comes to the GP clinic with the mother because of sudden onset of intermittent screaming with a few episodes of vomiting. Similar looks like it's a case of intussusception, but if you ask question of intussusception, everything will be negative. Then, and you missed asking the hernia or asking hernial orifice in the physical examination, and you totally missed the case, and you told the diagnosis as intussusception because you haven't asked hernia. There's only one thing you missed, and that was the case. So it's important. And then another question can come to you that mother already noticed a lump on the inguinal area, but suddenly child is getting really irritable or having like more episodic onset of vomiting or intermittent screaming. Or sometimes they can give you like a 3-month-old irritable boy for 3 weeks, mother noticed lump. This case is like just a normal reducible hernia. And this case is the irreducible hernia or incarcerated hernia. Okay. So in this case, history will be totally same, nothing much to add. In the PFE, same like before, you will do everything, but don't miss the inguinal orifice. So you will say, with the consent of the parent, I would like to check the hernial orifice, genitalia, and parenal inspection. So what you are looking for in the hernial orifice, examiner asks. So you will say, doctor, I'm looking for any lump in the inguinoscrotal region. Then examiner say, yes, you can, this is the lump. They can give you a picture of a hernia. When they give you a picture of hernia, immediately you say, well, I can see there is a like 2 centimeter lump in the right inguinal region. Doctor, I would like to know if it is tender to touch. Is it reducible or irreducible? So that's the only thing you need to find out. Is it reducible or irreducible? If it is irreducible and child is having severe pain, that means it's an incarcerated hernia. If it is reducible, child is not having any problem, that's a reducible hernia. Okay. So very important to ask to the examiner that if it is tender and if it is reducible or not. Otherwise, you can ask, doctor, I would like to know if the cough impulse positive, if I can get above the mass, if it is tender, reducible, irreducible. You can ask those questions if you have time, if you have enough time. But most important question is tender, if the overlying skin is red or not, because you will see it in the picture. If it is red, then comment on it. Otherwise, don't need to ask it. But important is these two, tenderness and reducibility. Now, once you've done that, then you come for the management. Say from the history and physical examination, most likely your child is having a condition called incarcerated hernia. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. Now, hernia drawing is very hard, right? So I don't know how you are going to do that. So what you can do, you can draw something like that, and you can show this is the hernia. Okay, nothing much. So say that, well, a hernia is a protrusion of part of a gut or fatty material through a weakness or opening in the tummy wall. It is usually seen as a bulge or a lump under the skin. So what is hernia? It's a protrusion of gut or fatty material through a weak part of the tummy wall. In a simple hernia, the bowel or the fatty tissues are usually able to move freely in and out of the defect, which we call reducible hernia. Now, if some part of the gut becomes trapped and cannot return it to the tummy, there is a risk that the blood supply of that part of the gut can get cut off. And when at that time it becomes really painful, overlying redness, and it will be very tender to touch. And that condition is called irreducible or incarcerated hernia. I am suspecting your child is having the incarcerated hernia at this time. John, it's really an emergency condition. I need to admit your child now. And also, I will call my senior and also involve the child specialist for further management. As of now, give, please do not feed him or let him drink water. I will put an IV line and start him on IV fluid. Most likely, the specialist will go for surgery to put the blocked gut back inside. Please don't get scared. We will do our best to manage his condition. I understand you might be really worried about your child. I would do the same if I was in your position. But I want you to know that your child is in the best hand and we have a very good team of doctors who will take care of your child. Okay, so reassurance and reassurance and reassurance. So that's the mainly the management of incarcerated hernia. Okay, so nothing by mouth, putting him on IV fluid. You don't need to do any investigation for incarcerated hernia. Okay, it's a clinical diagnosis. Child needs to be operated. That's the main treatment. No need of doing any investigation. Now, our last case is the duodenal atracia. Any questions so far? Am I being so fast that you guys cannot understand or anything? You guys are able to catch me? Good. All right. So for duodenal atracia, this is a very important case for your exam. So as I said previously, duodenal atracia comes with like vomiting within 24 hours of birth. So see this question, you are working in a small country hospital as a HMO, which means hospital medical officer. You have been called to talk to a 27-year-old mother, Janil, who gave birth to a baby boy 24 hours ago. She started breastfeeding, but he has vomited several times, some greenish fluid, and hasn't passed meconium yet. The neonatal checkup did not reveal any pathological findings, especially anus was present. An abdominal X-ray is provided. Take a brief history, explain X-ray findings to the mother, discuss the most likely diagnosis and management with the mother. Okay, so history, explain the X-ray to the mother. So that's important. And most likely diagnosis and management. So this is how it looks like. Duodenal atracia looks like a double bubble sign in the X-ray. This is the double bubble. In a normal person, you will never ever get this double bubble. This one you can get the like just below the left diaphragm, you can get some stomach shadow. That's normal, but this shadow is not normal. So in here again, the same thing. So you have to say, I understand that. So first introduce yourself, reassure the mother, congratulate the mother for having a baby, and then say, I understand that you must be really worried because your child has been vomiting after the birth. Please don't worry, your child is in a good hand and we will take best care of him. Make sure you ask hemodynamic stability from the examiner and then start asking question. So start asking the vomiting question. When did it started? How many times so far? Color, volume, order, all those questions. Okay. So how long after the feeding the vomiting comes? Is it forceful projectile? So all those questions you will ask in here. And then same differential diagnosis will be the same like before. Clear? So all the similar question you will ask and then ask about the well baby binds and family history of any tummy problems. One thing in the binds is important to ask is that duodenal atresia is common in patients with Down syndrome, right? Now, how you can find out in the binds when you ask how was the birth of the baby, Was he a term or preterm baby? Can I please ask that did you have Down syndrome screening during the pregnancy? And please forgive me for asking it. Can I know what was your age at the time of your pregnancy? Sometimes they will obviously provide it, like in here they provide it's a 27-year-old mother, you don't need to ask it. But if it's not given, then you can ask the age at conception, because once the conception becomes like elderly primigravida, or like after 35 year, chances of getting Down syndrome is increased. So you can ask it. But I would say just one question is appropriate, like ask that if you have any Down syndrome screening during the pregnancy or not. That's an important thing, because in this way you will let the examiner know that you know that duodenal atresia is common in Down syndrome. Otherwise everything is same like before. In the PEFE, same question, all the general appearance, vitals, growth chart, all things you will ask here. Then you start explaining the X-ray to the mother. Now, explanation should be really simple. You don't need to use anything which sound medical. So you will say, well, I'm going to explain the X-ray of your baby, which we have done. See that this is the X-ray of your baby's lower chest and tummy. So this is the X-ray of your baby's lower chest and the tummy. Then you will say in the X-ray, some looks black, some looks whitish. So go to the X-ray and show it. So in the X-ray, some looks whitish, some look black. Blacks are mainly those who contains air, and whites are usually which contain fluid and bony structure. Now, if you look at here, these are the lower chest. These two are the lower part of the lungs. That's why it looks blackish. And these are the rib cages of your child. Now, if you look at the tummy, you can see there is two blackish shadow in here, which we call double bubble sign. In a normal child, these blackish shadows are not there. This particular double bubble comes up in a specific condition called small bowel obstruction, specifically which we call duodenal atracia. Are you with me so far? Well, let me draw a picture for your better understanding. So draw the picture and say, so this is the food pipe. Food usually comes from the mouth, then goes into this tube-like structure, then to the stomach, and then to the gut. In your child case, I'm suspecting the first part of the gut called duodenum is absent. And that's why whatever you are giving your child to drink, it's not going into the gut and it's flowing back to the mouth and causing the vomiting. I'm really sorry. It's not an uncommon condition, but it's a surgical emergency. Now, as we are in a rural hospital, I need to refer your child as soon as possible to a tertiary hospital. So I'm going to arrange a emergency pediatric retrieval team who will take your child to the hospital as soon as possible. In the hospital, they will admit your child and he will be assessed by a pediatric surgeon. In the meantime, please do not feed your child or drink anything. I will put an IV line and start on IV fluid. If your child keeps on vomiting, we may need to insert a small tube into the stomach to aspirate any contents in the stomach. I understand that you might not thought any of this today, but sometimes something happen in which we don't have any hand. But now that you are here with us, we will take the best care of your child. Please don't worry, your child will be fine. The outcome of the surgery is very good. And sooner we manage it, the better it is. Okay, so you don't need to discuss a lot about it. Remember, see that how I am doing. Everything is same. All these cases, the management is same. Sending to the hospital, seen by the specialist. Do not eat and drink. IV fluid. If keeps on vomiting, then NG tube, and then surgery. See that you just need to remember this important thing, nothing else. Clear, guys? Any questions? So that finish our pediatric vomiting. We might have two or more, like one or two cases left. Now that usually we will find it out when we will take the role play session. In the role play session, we discuss mainly the 1 year, all the important cases in relation to the theory that we take. So we will go through the cases and then we will see if we have missed anything, then we will discuss in our role play session. This is how it works. Now, just a couple of things I wanted to discuss with you today. I know that many of you wanted to join our courses and you are waiting for the 2 weeks free session to be finished. But I would advise you that there are lots of students who are joining the course, and we would not take a lot of students just to maintain the tranquility of the class. So if any of you are interested, make sure that you at least send us an email or messenger that you want to keep a seat for the session, 5 month session, so that we can take your name and we can keep a seat for you so that you don't miss it. That's one of the important thing you should do. And if you guys have any question, any queries about the course, feel free to ask it in here or anytime in our sessions, or there are also our team members working. You can send us a message in the messenger, or also email will be sufficient. Any questions so far? So you guys are enjoying the sessions, or do you think it's just like a normal session? So Dr. Mukta, the positive findings of pyloric stenosis, as we discussed, like normally what will happen, the child with 2 to 6 weeks age group coming to you with vomiting, which is projectile. Soon after feeding, they will vomit and they will feel hungry just after the feeding. They will lose their body weight. So that's one of the important part. And they will be dehydrated. On physical examination, you can get some pyloric mass and visible gastric peristalsis. All right, then. So we'll finish our session tonight. And if you guys have any question in regards to our sessions or anything, feel free to ask it. Thank you all. Have a good night. Bye.